We are using B-Bron actually.
Even we are using B-Bron actually.
Okay.
But nothing like Cortex.
Nothing like Cortex. I agree completely.
The B-Bron needles are very
you,
sharp.
Have you used Vigon?
No.
It's not as good, but yeah, but
जो सबसे अच्छा है वही market से निकल गया. Even the Cortex endotracheal tubes were so good, and we have those Helmer tubes which are not very good.
Madam, you are basically doing advertisement of Cortex on a very commercial or a professional platform.
I don't have any shares with Cortex.
You have to declare that before giving that statement. No conflict of interest, no financial interest implication here. Dr. Madhuri and Dr. Nishant, everything is ready, I think.
Okay, sir. So a very warm welcome to all, and a warm welcome to the ISA National Clinical Practice Oriented Webinar Series. Today is the 7th in this series, and again it is on a very important topic of labor analgesia. This is an initiative of the ISA leadership under the honorary secretaryship of Dr. Sukhminderjeet Singh Bajwa sir, and the program head for the ISA clip series is Dr. Manoj Kumar. And for today's session, we have two young anesthesiologists as academic facilitators. Dr. Tanveer Singh, he is an associate professor at DMCH in Ludhiana, and he's a very hardworking honorary secretary of ISA Punjab. And with him will be Dr. Bhavna Gupta. She's again a very excellent assistant professor from AIMS in Rishikesh. So over to both of you to carry forward the session. Bhavna and Dr. Tanveer, please.
Thank you so much, sir. A very good evening to one and all. A warm welcome to our esteemed senior members, distinguished panelists, coordinators, and delegates who have gathered here today. I express my gratitude to our very dynamic honorary secretary, Dr. Sukhminder Singh Bajwa sir, for his dedication, support, and guidance throughout this CLIP webinar series. His presence as a key member elevates the significance of all our discussions. May I request, sir, to address the gathering, please?
Thank you, Bhavna. But yeah, I think you prepared a speech with some good words. Unnecessary चने के झाड़ पे नहीं चढ़ाते होते secretary को ऐसे बोलकर. These are two words. Actually, you have to be humble. You can't give a dynamism to the person. Actually, anyway, thank you for all the kind words you have, your faith you have in me. Definitely this one webinar panel discussion is of utmost importance, because in everyday life, majority of us, especially the practitioners, as well as the students who are studying in the institutions, we have seen the cases of labor analgesia, and there are numerous doubts, numerous myths, so many fallacies, so many truths associated with labor analgesia. And because every day so many questions come to our mind, so many things come into mind, because this is a branch which is dealing with two lives at a moment. Because majority of the time when you are giving the labor analgesia, you are not just careful about a mother, but a fetus also. And other things are also because you have to involve another specialty, the obstetrics. The obstetricians have to be with you. I will tell you just one experience of mine. When I was instituting this labor analgesia, putting the epidural, the best help I got from my wife. She being obstetrician, she told the patient, you just make a good position, because sometimes the position, the pains are there, position is very difficult. So she told me one thing to the patient: the good position you make, it will get into the first break, and it will be very good and safe for the kid. That was the thing which it made the patient obey to that command of an obstetrician in such a good manner. And I got I think very smoothly I was able to, she was an obese patient, I was able to introduce the epidural in the first attempt only. So leave aside that thing. That's why we have got one of the two most dynamic people. Those are the real dynamic. That is Vimi Rivari. She is doing obstetric anesthesia for a long time into the administration as well into the academics. And Dr. Bharti Kalra, she is I think one of the core obstetrician of entire Karnal and adjoining of the Haryana region. She is attending so many patients every day. And to attend to them, all the panelists are there. They are well, I think many of them are obstetric degrees also. They are holding OBS degrees also, as well as anesthesia degrees also. So I think rather the best person to introduce them will be Dr. Bhavna and Dr. Tanveer. So kindly go ahead. We should start this session now, please.
Thank you so much, sir. With that, I extend a hearty welcome to our esteemed panelist. We have a very passionate professor, Dr. Vimi Rewari. She has affiliation to pain medicine and Department of Anesthesiology at AIIMS New Delhi. We are really honored to have you as a moderator, ma'am. And her areas of interest are critical care, hepatobiliary, liver transplant, obstetric care, acute pain, and simulation. Ma'am has numerous achievements and awards to her credentials. She has received a Commonwealth Academic Staff Fellowship in Liver Transplant Anesthesia and Critical Care at St. James University Hospital, Leeds, NHS. We welcome you, ma'am, to this webinar series. Then we have in our panel, we have Professor Kaushalya Chakravarti. She is professor and HOD in the Department of Anesthesiology at Government Medical College, Telangana. Ma'am's area of interest are obstetric, critical care, anesthesia, and analgesia for high-risk obstetric patients. Ma'am has conducted numerous labor analgesia simulation-based workshops and is a project director for WFSA's Safe Masimo workshop at Telangana. She has also been past subspecialty editor at IJA and is peer reviewers in many numerous journals. We welcome you, ma'am. Then we have Dr. Shilpa, who is consultant anesthesiology at PD Hinduja Hospital, Khar, Mumbai. Ma'am's area of interest are obstetric anesthesia and simulation in obstetric emergencies. Ma'am has numerous awards and achievements to her credentials. She has received fellowship from Toronto in obstetric anesthesia, fellowship in pediatric anesthesia from Singapore, and also Mark's Symposium Award from Florida, USA. She is also joint secretary at AOA India and founder and present secretary from Mumbai AOA. Ma'am has numerous publications in international journals. We welcome you, ma'am. Then we have Dr. Bharti Kalra. Ma'am has received a fellowship in sexual medicine and also certified diabetes expert. She is ex-president at Karnal Obstetric Gynecological Society. She is certified in obesity management. Ma'am has received numerous awards and credentials. And also in WSA Con 2009, she has been first prize in paper presentation. She has numerous publications to her credit. And her areas of interest are cosmetic gynecology and female sexual health. We welcome you, ma'am.
Our next panelist is Dr. V. Srilata ma'am. Ma'am is Associate Professor KMC Kurnool, Andhra Pradesh, and ma'am's areas of interest are labor analgesia and pediatric anesthesia. Ma'am has worked as a Secretary ISA City Branch Vijayawada and got Best City Branch Award, and she has 8 publications to her credit, 2 paper presentations. She is a UG and PG teacher and external examiner for PG students. Welcome, ma'am.
Thank you.
Our next panelist is Dr. Samina Khatib, ma'am. She's Professor, Department of Anesthesiology, Government Medical College, Cancer Hospital, Aurangabad. Ma'am's areas of interest are obstetric anesthesia, pain management, onco-anesthesia. She is a recognized postgraduate and PhD guide, member of Board of Studies, member of Academic Council in PIMS Teams University, WFSA Scholarship for 2021. She is the recipient of this. She has a Special Achievement Award in Maharashtra State ISACON 2017 in Nanded. She won the first prize for paper presentation in WISA Con 2009 in Aloka. She's a recipient of Women's Scientist Scholarship from Urdip, Pune. She is the recipient of Intellectual Property Rights Government Merit Scholarship, the recipient of Dhirubhai Ambani Undergraduate Scholarship, recipient of SAT Memorial Scholarship, California, and faculty at a number of national and international conferences. She has 15 publications in national and international journals and 2 book chapters to her credit. Welcome, ma'am. Our next panelist is Dr. Deb Sanjay Nag, sir. Sir is head of the department and head consultant anesthesiology, Tata Main Hospital, Jamshedpur. Sir's areas of interest are obstetric anesthesia, difficult airway, perioperative patient safety, quality indicators in anesthesia, hospital management systems. Sir is ex-president ISA Bihar Jharkhand, member of World Association of Medical Editors, organizing secretary ISACON East Zone 2016, editorial board member of World Journal of Clinical Cases, associate editor IJ East and Northeast, and reviewer in Indian Journal of Anesthesia. Recipient of Professor T.N. Jha Gold Medal State 2004 and 2005 and National 2006. Best Speaker at AIS Mock 2012 and 2023. Best TQM paper at AIS Mock 2015. Best Long Paper at AIS Mock 2020. Ex-B. Braun Medical Trust Foundation Scholar. Sir has 43 publications, 3 chapters in books, and over 4,000 citations to his credit. Welcome, sir. And with this, I would hand over to Dr. Vimi Rewari, ma'am, our moderator for this session. Please carry on.
Thank you, Tanvi. And good evening to everyone. And I welcome you all to this edition of the Clinical Practice Oriented Webinar Series, which is an initiative by the ISA National, also called as the CLIP in short. And today we are going to be talking about labor analgesia. And I'm sure all of us will agree that labor and delivery is one of the worst or most painful experiences in a woman's life. So much so that the fear of labor can even kind of incite a laboring woman or a parturient, an expecting woman, to request for cesarean section, elective cesarean section. And that is one of the reasons for the increasing rates of cesarean sections, the lack of provision of labor analgesia services. So requesting for labor analgesia is a fundamental human right. And as anesthesiologists, I think it is our duty to provide labor analgesia services to laboring parturients. And therefore, the aim of this panel discussion is going to be to look into the various techniques of labor analgesia, the ways of implementing those techniques, the complications, the advantages, the disadvantages, and also the myths and controversies which surround the institution of labor analgesia. So before we go into these, I think it will be prudent to talk about a little bit about the mechanism of labor analgesia and how it is different from other acute pain scenarios. So my first question is going to be to Dr. Srilata. Dr. Srilata, could you please, could you please talk briefly about the pathophysiology of labor pain and the various advantages of instituting labor analgesia? What advantages are there to both the mother and the fetus by providing labor analgesia? Dr. Srilata?
Okay, madam. Good evening to all. Good evening to all.
Good evening.
Is it audible to all?
Yes, ma'am. You
Yes,
go ahead.
sorry.
Kindly go ahead, ma'am.
My topic is pain pathway. Mainly, I would like to deal with this. So, as labor itself is very painful, not unbearable. So the stages is stage 1, 2, 3. So stage 1 is from onset of labor to full dilatation. Stage 2, full dilatation to delivery. So the mechanism of pain is due to stretching of these mechanoreceptors in the uterus and cervix. So due to the pressure and contractions of the uterus, so there may be the mechanoreceptors will release the serotonin and acetylcholine, so histamine, bradykinin. So these will cause the pain. So these can be during first stage, the pain is due to visceral origin. It is diffuse, not localized. So these are carried through inferior, middle, and superior hypogastric plexus. So mainly in first stage, the fibers are C fibers. Whereas coming to second stage, so this is more local. This is due to stretching of pelvic muscles by the fetus. So the narrow pathway is to pudendal nerve, S2, 3, 4. mainly AD fibers. So this is localized, sharp in nature. So this is somatic in nature. So the pathways are maybe central and peripheral. So what I have told is peripheral. From central is that dorsal rami of the substantia gyrotenosa in the spinal cord to the, it will cross opposite side and spinothalamic tract. And finally, it enters the thalamus and cerebellum. So descending is in the opposite direction. So because of these all, the knowing the pathways and all, we can give the drug, because in first stage only T10 to L1, whereas in second stage the innervation is S234. So depending upon that, we can calculate the what is the correct dose and all. So coming to advantages means, if there is pain means there may be stimulation of catecholamines and so sympathetic innervation. So there may be hypertension, tachycardia, all. So the placental, placental circulation will also be lesser, so that there may be epiplacental insufficiency, say, so baby may be geopardized. So if you prevent all these catecholamine release and sympathetic tone, so there may be better placental circulation and fetal well-being also be good. That's why it is better to go for labor analgesia. And also we can decrease the cesarean section rate also with this. So my topic, briefly I told.
Yeah, thank you, Dr. Srilata. So in the first stage of labor, basically, the pain, you need to block the pain sensation from T10 to L1. And in the second stage, from S2 to S4.
4. So somatic.
Yeah. And the difference in the quality of pain, it is dull in the first stage and more sharp in the second stage, and may require a higher concentration of local anesthetic to kind of get to take care of that pain, right? And also, besides the increase in catecholamines, even the hyperventilation, which is initiated because of excessive pain, can lead to respiratory alkalosis, which can shift the oxyhemoglobin dissociation curve and prevent oxygen delivery to the fetus. So that could be one of the other mechanisms which can cause harm to the fetus, besides the increase in catecholamines. Okay, so now that we understand the mechanism of labor pain and the harmful effects of labor pain on both on the mother and the fetus, we can now go on to the different techniques of labor analgesia. So I'm going to start with a hypothetical scenario and followed by some questions. And my next question is going to be directed towards Dr. Sanjay. And my scenario is that a 25-year-old primigravida at 39 weeks of gestation presents to the labor room with painful uterine contractions. The patient is educated and is requesting for a labor epidural. The obstetrician confirms the presence of regular contractions, uterine contractions, suggestive of true labor, and per vaginal examination finds a cervical dilatation of 3 centimeters. So Dr. Sanjay, we can start by discussing the various techniques of neuraxial labor analgesia that you can offer to this patient, and then we can go on further questions once you kind of deal with this one.
Thank you, ma'am, and thanks to Dr. Srilata and you for actually summarizing the genesis of the labor pain so that the solutioning we provide, people can relate to it. So basically, whenever any patient comes in for labor analgesia per se, there are actually few steps to be followed as a checklist in the labor room or the adjoining area before we move ahead with any analgesia. First is obviously, as I said, communication with the patient relatives, explaining to them what is going to happen. As Bajwa sir just said, that the patient has to be told what position has to be taken, what steps will be followed subsequently, and how the analgesia will set in. So explanation and good communication with the patient, I think, is the first step, and it resolves at least 50% of the problems we anticipate during that. Obviously, while doing that, we do take a focused history of the patient, see whether there are any comorbidities or anything, and then a targeted physical examination. Obviously, we look for the vital signs a chest examination, a cardiac auscultation. These are some good practices we should follow. We should also review the lab examinations, because most of them, when they come in for labor, there will be some lab investigations available. So the recent ones we can review. Although there is no specific requirement of lab examination to be noticed, but one thing I sound everybody out, across the country, we are seeing a large scale increase in dengue cases. So that is why it may not be typical textbook style, but it is always prudent in such a season to look at a CBC and the platelet count possible. And obviously, we have to formulate an analgesia plan. So it is based upon the anesthesiologist and the patient, what is best for her. Then perform an equipment checklist, the basic resuscitation material, the syringe pumps are functioning or not. All of that we do. Then we see whether the basic resuscitation equipments are available or not. Obviously, we next take a consent from the patient, apply the maternal monitors, apart from a CTG monitor, the blood pressure, heart rate, and the pulse oximetry, monitor fetal heart rate, and then perform a team out, like we do it for our surgical safety checklist, WHO checklist. A team out is done once in the theater. We are doing it in the theater or in the labor room if we have a suit, do that. So this is in brief the checklist which we follow. And another good practice would be to see whether there are any contraindications to epidural analgesia. So there are only 8 of them. One is obviously a patient refusal in the case given, that is ruled out because she herself is volunteering for it. The last third and fourth will be second and third would be obviously the technique, the ability of an anesthesiologist to perform that, or the setup is not competent enough to do that. So these are some of the things we should, obviously in this case it doesn't apply. The next would be the history taking or examination would reveal this if there is any space occupying lesion leading to increase in intracranial pressure. And the other two are coagulopathy or any pharmacological anticoagulation in the very recent past. And the last one is if there is any massive maternal hypovolemia due to a hemorrhage or something like that. So we rule out all the contraindications and then we move to the techniques which are available. Each technique has its advantage, each technique has its disadvantage. The most common one which is followed across the world is obviously a continuous epidural analgesia which we provide. The advantages are it is continuous and there is no dural puncture involved and ability to extend the analgesia over a prolonged period of time. But there are certain disadvantages also. There is a slow onset, a larger dose of drug is required. There is a general possibility, I know the possibility is very less because the concentrations are very low, risk of maternal and anesthetic systemic toxicity, and could be due to some fetal exposure to the analgesic drugs also. The next common one, which is gradually picking up of late, is the combined spinal epidural. So there is a continuous analgesia is there. A low dose is needed because obviously if we put in a drug intrathecally, so a lower dose will be required for the continuous epidural part of it. The advantage main one is over here is that the onset of analgesia is quite rapid. And if it is in the later stage of labor, it also covers for the sacral analgesia part of it. And complete analgesia during the initial part of labor can be achieved merely through intrathecal deposition of opioids. And there is decreased incidence of failed epidurals also if we are doing a CSE technique, at least literature shows that. But the minor disadvantages are that there is an increased risk of pruritus in these patients and a theoretical risk of fetal bradycardia in these cases. Now coming to the next one, which is not very common, very rarely used nowadays, the continuous spinal one. The continuous spinal, obviously we put in a catheter in the intrathecal space and use it to provide continuous analgesia. But the point over here is there is a very high incidence of PDPH in such cases, and it is preferably avoided as an elective one. The point to note over here is till around 25 years back, this was one thing which was sometimes practiced. But after the onset of we seeing a lot of cauda equina syndromes through intrathecal catheters, I think this has been discontinued. The only place in current practice where continuous spinal analgesia has a role today is inadvertent dural punctures. So once we have punctured the dura, possibly having a continuous spinal could be one of the possible mechanisms through which we can provide analgesia. And next is a continuous caudal, again rarely used because of the possibility of fetal injection, also inadvertent one. And there is a possibility of higher infection rate, possibility of larger volumes being needed, especially to cover for T10, T11, T12 in the early part of labor. But again, if there is a local site infection at the intended lumbar epidural space, this can be one of the options. And the last one, single shot injection, it is technically simple. It gives an immediate onset of analgesia over the next 15-20 minutes if we are only using epidural. But again, it gives us a limited duration of analgesia, although it can be used if the analgesia is started pretty late in labor, but these are the possible alternatives. Now, if we are using all of these, there are 2-3 mechanisms through which we can do. One is obviously a continuous epidural. Second is there is a dural puncture epidural analgesia theory also there. So what we do is we don't deposit any drug to the dural puncture. We just make a puncture in the dura and continue with the epidural infusion. So what it does is then it is perceived, not very strongly theoretically proven, but there are literature proving that the transmission of the analgesia developing is reasonably faster than a pure epidural alone. And obviously, we have other mechanisms like the patient controlled epidural analgesia. It either can be through intermittent boluses through a patient controlled analgesia, or a continuous flow is there and the epidural analgesia is activated by the patient as and when needed. And there are the other techniques also where there are intermittent boluses through programmed pumps which can deliver the epidural anesthesia. So this is in brief the various techniques and modalities which are available. Each has its own advantage, disadvantage. I think based upon the anesthesiologist and the patient and the discussion which happens between the two, the modality has to be customized for that.
Thank you, Dr. Dev, for beautifully summarizing the advantages and disadvantages of various techniques. So my question here is, for this patient, what would you recommend? This patient is nulliparous, very early in the first stage of labor. Uterine dilatation is only, the cervical dilatation is only 3 centimeters. So do you think the timing is right for a labor epidural, or would you wait for further cervical dilatation?
Yeah, ma'am, this is the right opportunity to bust some myths also. Earlier, there was this concept that if you initiate labor before 4 centimeters dilatation of the cervix, there is possible chances of prolonged labor, cesarean deliveries and instrumental deliveries, the incidence is increasing. But over the last 10-15 years, whatever research has shown us, it is actually not so. And if we are able to initiate labor analgesia at this stage only, what it happens is it increases the patient satisfaction also. And then we can customize the delivery of the drug based upon the need of the patient. Because this is a nulliparous woman, we know that the duration of labor as compared to a multiparous woman would be longer. So that is why I think 3 centimeter dilatation is the correct time to place in the epidural catheter. And possibly I would put in a intrathecal fentanyl also 25 to 50 mics so that the analgesia onset is immediate. And that gives the maximum satisfaction. And subsequently, I'd start a background bolus of low dose bupivacaine 0.0625 or 0.1%. If a PCA pump is available, maybe 3 to 4 ml per hour with a 5 to 10 ml boluses at 20 to 30 minutes. That is how I start the labor analgesia part for this patient.
So I would also tend to agree with you. So there is no restriction on the timing of neuraxial analgesia based on cervical dilatation. So maternal request is indication enough for instituting labor analgesia, irrespective of the cervical dilatation. And also for this patient, like you rightly said, the patient is nulliparous with a low threshold for pain. I would probably also go for a combined spinal epidural because the patient is already having excessive pain and is requesting for analgesia. That means the VAS score or the NRS score is more than 5. And by using a combined spinal epidural, the onset of pain relief will be much quicker and it will satisfy the patient much more. In comparison to a multiparous patient where you expect the duration of the first stage of labor to be not so much as a nulliparous patient. So and the intensity of pain, the patient maybe has already undergone some kind of, the previous deliveries did not have a labor epidural in place and maybe is you kind of more familiar with that kind of pain. So the intensity of pain varies from patient to patient, I would say. Maybe that's not related to the parity of the patient, but depends on the patient's tolerance. So that would also govern the choice of your type of neuraxial analgesia. If the patient is in very early labor and the intensity of pain is less than 4, say, then maybe a simple labor epidural would suffice. But where the patient's VAS score is more than 5, I would probably also go with the combined spinal epidural. So one last question, Dr. Sanjay, what position would you be comfortable in kind of putting in the epidural?
See, again, this is a slightly tricky question in the sense, none of the two positions, a lateral position or a sitting position, has any particular benefit one over the other. I personally prefer the sitting position, positioning a stool below the patient's legs with her sitting on the OT table. But whatever position you adopt for putting in an epidural, the recommendation is that after you thread in the epidural catheter, put her in a left lateral position for at least 15 to 20 minutes. So I would put a epidural catheter in sitting position, but after I put in the catheter, I will keep her in a left lateral position for 15 to 20 minutes. The monitoring part of it, while the epidural is being given, till the effect of the epidural analgesia is there, the hemodynamics should be monitored every 3 to 5 minutes. But once it is established, anything between 15 to 30 minutes frequency is good.
Thank you, Dr. Sanjay. So now that we have established that labor epidural neuraxial analgesia is the gold standard for labor analgesia, provided there's no contraindication, I would like now to discuss about the methods of initiation and maintenance of the labor epidural. And my next question would be to Dr. Kausalya. Kausalya, what would be your choice of local anesthetic, the preferred dilution and the volume for various types of neuraxial analgesia?
Yeah. We usually prefer low dose mixtures or ultra low dose mixture. Ultra low dose mixture is either 0.0625% of bupivacaine or 0.08% of ropivacaine. And when we are using a low dose and an ultra low dose mixture, it's always better to add an adjuvant. The adjuvants that we usually add is opioids. And the opioid which we usually use is only fentanyl, because fentanyl is not available in India. And we have seen, we use fentanyl way back, but then it used to cause more amount of fetal bradycardia. So we are left using only with fentanyl. So for initiation of the labor epidural, it has to be in this patient, since we have already given a CSE and the patient has received intrathecal opioid, it is always better to wait for the next pain or another 90 minutes, 1.5 hours, and then initiate the labor epidural. So initiation of the labor epidural can be either an intermittent boluses, that which can be manual, or it can be a continuous infusion. Continuous infusion, it can be given either as a continuous infusion of through a syringe pump, or you can have a programmed intermittent epidural boluses also, which are available now in India. In programmed intermittent epidural boluses, actually we program the boluses, and each bolus will be given around 8 to 10 ml, and this is set around a period of time interval of around 20 to 30 minutes, and sometimes in some centers they set it around 45 minutes also. So every 45 minutes, the machine itself, the cassette itself will deliver a bolus of 8 to 10 ml of the local anesthetic solution with an opioid to the patient. or else you can either go to the patient in every 1 hour and you can give the manual intermittent boluses. The other one is continuous infusion, which can be set either with a syringe pump or you can set it with a Baxter pump. The main problem with continuous infusion is since it is given as a continuous infusion, the patient can have more dermatological involvement of a particular dermatome, and the patient can have more amount of numbness of one segment of the body. Okay, and the other one which can be given is patient-controlled epidural analgesia. So patient-controlled epidural analgesia can be either programmed to the patient's requirement or it can be along with a programmed intermittent epidural boluses. So here also the patient can have a background and then a bolus. So the background infusion can be, it will act like a continuous infusion. So we don't prefer the background infusion. So we give only patient-controlled epidural analgesia, where the patient can, whenever the patient feels that she needs a bolus, she can press the button so that it will deliver a bolus. So this machine will have a lockout interval and also the maximum amount of the drug that can be delivered to the patient, so that the patient will have more amount of safety.
So that mostly most centers, what we are practicing is intermittent bolus, either manual or automated boluses. And the disadvantages of a continuous infusion, like you said, was that it can lead to patchy, intense blockage. And also there is increased incidence of motor blockage as well. So the patient tends to not assist with the vaginal delivery as much. So that is a side effect. And in most centers worldwide, continuous infusions are not really used and programmed intermittent boluses are more common. Because according to the literature, that has more disadvantages, continuous infusions. So what is your drug of choice now that we have bupivacaine and ropivacaine both available? So what would you prefer for obstetric analgesia?
Actually, it depends upon your center. Both ropivacaine and bupivacaine are almost the same, but then we have found that with ropivacaine, the amount of the motor block is very less. It is minimal. So we prefer ropivacaine. We prefer ropivacaine 0.1% with 2 microgram per ml of fentanyl. But yes, if ropivacaine is not available in your center, even bupivacaine is okay, but you should not exceed the concentration of bupivacaine more than 0.1%. It's always better to go for 0.0625% with 2 microgram per ml of fentanyl. And then if the patient sets into active labor and the patient is not having enough pain relief, then you can increase the bupivacaine concentration to 0.1%. Or if you have ropivacaine, always better to use ropivacaine 0.1% with 2 microgram per ml of fentanyl.
Absolutely. So I think that answers most of our questions. So if ropivacaine is available, then definitely ropivacaine because it causes less motor blockage. But if not, bupivacaine is equally acceptable and low or ultra low, and concentrations ranging from 0.0625 to 0.125 can be used depending on the patient's need and the stage of labor. So now I shall present another case scenario followed by a question which I'm going to direct to Dr. Shilpa. So now we have a 30-year-old third gravida, para 2, who presents to the labor room with history of labor pains for the last 4 hours. On obstetric examination, the cervical dilatation is about 7 to 8 centimeter, and the parturient is requesting for labor analgesia. So given this scenario, Shilpa, what would be your technique of choice?
So she is G3 and she's already have 2 deliveries in the past, right? So I know that this is a multi-para and her duration of the second stage will be really short, maybe 15 minutes to 30 minutes, not more than 45 minutes. So in this particular scenario, I will quickly, while I'm preparing myself and she's in a lot of pain, we do get such scenarios very frequently. So my first choice would be a single shot spinal to this particular patient because we need a rapid onset. And normally a single shot spinal, I use a 25 gauge Whitaker spinal needle and use 2.5 milligrams of 0.5% heavy bupivacaine with 15 mics of fentanyl, diluted to about 1.5 ml with normal saline. And the pain relief patient achieves within 2 to 3 minutes. and the patient is very comfortable. Now, if this patient is fully dilated and is not able to sit at all, we also have Entonox with us. And in very rare scenarios, we would use Entonox in this particular patient who is going to deliver in like 5 to 10 minutes, where you don't even have time for adequate spinal administration.
That's right, Shilpa. So in second stage of labor, when the delivery is imminent, a single shot spinal is the technique of choice if the patient is cooperative. And if not, I think Entonox would be a reasonable choice for provision of labor analgesia. Okay, so moving on, my next question is for Dr. Srilata. What is the effect of neuraxial analgesia on the course of labor? Does it affect the course of labor? Dr. Srilata? So, Dr. Sanjay, can you answer? I don't know whether she's probably disconnected. Dr. Sanjay, would you be comfortable answering this question?
Yeah, so this is about the course of labor. Yeah.
Effect on the first stage and the second stage of labor.
Effect on the first stage, there for primies, I think there is a slight increase in the duration of labor, but there, as per whatever reports are available, there is no increase in the incidence of cesarean sections or instrumental delivery. Instrumental delivery would be needed possibly in some cases where there are some other diseases which doesn't allow for a Valsalva or push by the mother. But otherwise, there is only a marginal increase in the duration of first stage of labor, but it doesn't adversely impact the fetus or the mother in any way.
Dr. Shilpa, do you have anything to add to this?
So I completely agree with Dr. Sanjay. The course of labor, there are a lot of studies and there are mixed reviews. So some studies say that the second stage of labor is prolonged by 2 hours in primigravidas and maybe 15 minutes to 30 minutes in multigravidas. However, there are a lot of reasons behind it, and also the instrumental delivery is more in patients who have received epidural. But again, now some studies were done when not very ultra low dose and low dose was used. Okay, so patient used to have more of like some motor block and the patient was unable to push. So that is the reason for assisted vaginal delivery. Now, the recent studies have shown with ultra low dose that there is not very significant difference whether or not you use an epidural. And there is more propensity and more tendency for an obstetrician to use vacuum or forceps because the patient has very good pain relief. So that's so,
right.
But not, it really doesn't make a difference. You ask a laboring patient how comfortable she is when she's pain relieved. She doesn't mind even 15 minutes or 30 minutes of delay.
I couldn't agree with you more. So what the literature says that institution of labor epidural might slightly decrease the first stage of labor, especially in the nulliparous patient, because the cervical dilatation happens very quickly. And there is, like you rightly said, these studies are older, but there is slight increase in the second stage of labor, ranging from 30 minutes to 90 minutes. But with the use of ultra low dose local anesthetic, low concentration of local anesthetic, I'm sure there is not much of a difference, and there is no major impact of labor epidurals on the course of labor. So. Yes. Going on to the next very important topic is troubleshooting in labor epidural. So, Dr. Shilpa, coming back to you again. So we can talk about the different problems that one encounters during labor epidurals. And the first and the most major ones, and I think we are getting a lot of questions in the chat box also regarding this, is an accidental dural puncture. So what does one do while doing a labor epidural if one has an accidental dural puncture? How do we go about it? Which is a possibility in most of these patients, especially obese, difficult epidurals. This is very common.
So accidental dural puncture is more common in obstetric patients because they are moving all the time. They're very anxious, and they're not able to give a good position because of the big abdomen in the front. Okay. So you have two options. One is either you continue the low dose spinal catheter, like you put the epidural catheter in the intrathecal space and manage it as a continuous low dose spinal catheter or an intermittent. Or other option is, see, it all depends. Nothing is right or wrong. It all depends on what you are comfortable doing. Other thing is you remove and resite it. I think, again, it all depends on where you practice. And what are your institutional guidelines? What is your infrastructure? What is your backup? What is your nursing expertise? So what I'll talk about what we do in our institution. So I work in a tertiary care center where it is center of excellence, especially for high risk pregnancies. And in our institute, 100% of patients take epidural. I think this is the only place in India where, or probably in the world, where all the patients take epidural. And that is because our obstetricians push it. Whatever the obstetricians say, the patients just follow it blindly. So when I get an accidental dural puncture, and it can be in any hands, any years of experience, we all get it on and off. So I put the intrathecal catheter, and I inform everybody on the labor floor. We have to be very vigilant with the patient monitoring. So what I do is I attach to this particular patient a multi-para continuous monitor, and the blood pressure is going every 5 minutes, especially when a bolus dose is given, or if it is a continuous infusion, again, the monitoring is done every 3 minutes of the blood pressure, and a plain pulse oximeter is attached continuously on the patient. Then you have to attach very visible labels on the epidural catheter, so that even if there is a change of staff with change of duty, nobody hampers or touches. We put a label, do not touch intrathecal catheter. And normally we have round the clock our junior anesthetist who is on the labor floor monitoring this particular patient. So I normally, how do I manage this is I give about 1 to 2 ml per hour of the same drug, which is 0.1% of levoanavin with 2 mics per cc of fentanyl. This is what we do, especially if it is a primary. If it is a multigravid, or it again depends. Some consultants in our department give a continuous infusion, and some would give every 45 minutes to 1 hour. They give 1 ml or 1.5 ml of bolus of the same solution. So this is how we manage. Now, again, for a junior staff, the reflex is as soon as you get a dural puncture, your reflex action is to just withdraw it. Okay, so this we have discouraged in our hospital, and we actually place an intrathecal catheter. And the other risk is post-dural puncture headache. So what we do is we place the catheter for at least 24 hours and remove it after 24 hours. We actually seal the tip completely after the baby is born so that nobody can inject anything. And we remove the catheter after 24 hours. This is what we do in our department.
So to summarize,
I think I would like to know what others do actually.
So,
And
I also practice the same technique. So if I have an accidental dural puncture, I generally put in the epidural catheter, the intrathecal space, and give intermittent boluses. We don't use an infusion. I give intermittent boluses depending on the patient's need. But to summarize for the benefit of the audience, so if you have an accidental dural puncture, there are 2 options to it. Either you insert the epidural catheter into the intrathecal space, where you will give low doses of local anesthetic with an opioid, again 2 microgram per ml of fentanyl. And you have to be very careful in injecting the drug, labeling it properly, informing everybody on the labor floor that that catheter is intrathecal and not epidural. Otherwise, accidents can happen. So that is one. If you're not comfortable with this, then you will have to remove the epidural catheter and resite it at another space. So many centers practice this also. And like you rightly said, there is no right and wrong. There are 2 options of doing this. Whatever you are comfortable with, both can be practiced easily. So the next common problem that you encounter with labor epidural is a patchy.
I think Dr. Sanjay wants to say something.
Yeah, yes, Sanjay,
Yes.
yeah, please.
Yes, sorry, ma'am. Actually, there is a different opinion over here. What happens is in such cases, if we thread in an epidural catheter, what we have observed is the incidence of PDPH. Obviously, because of a thicker puncture, the incidence is higher. But what helps is if we are able to negotiate the epidural catheter in a different space, and subsequently what we inject through the epidural catheter, it at times act as a tamponade. And possibly the incidence of the post-dural puncture headache is lesser in such cases. This is a theory, obviously, and no studies or not much studies currently available on this, but this is one theory on which positioning it in a different epidural space and running a continuous epidural through that could be one of the theoretical advantages.
So the proponents of people who insert the epidural catheter into the intrathecal space, the rationale behind is that that technique decreases the PDPH because the presence of the catheter in the dural puncture initiates fibrosis and helps in sealing that dural puncture hole much faster. So the incidence of PDPH actually comes down. So there is no clear,
Absolutely.
mechanism. So both, that's why I said, and that's why Dr. Shilpa said, both of them can be practiced and you can't say that one is better over the other.
Absolutely.
So it all depends on your comfort level and your institutional practice. Okay, any other comments on this? Any other difference of opinions? Dr. Kausalya?
Yeah, we too put the catheter intrathecally. But what we have noticed is whenever we put the catheter intrathecally and continuously, we give continuous infusion, and we use ropivacaine with fentanyl. And because whenever we are using levobupropion, the potency of levobupropion is much lesser than what we found in labor epidurals. It is lesser than with ropivacaine. We are more comfortable with ropivacaine. And as Shilpa has said, we leave the catheter for 24 hours. And we seal the catheter and we label the catheter. And even on the case sheet and everything, we label that the catheter should not be handled by anybody except by the anesthetist.
Yeah, thank you, Kausalya. So moving on to the next problem that one might encounter is that if you've placed the epidural and you are more or less sure that it's in the right place, but the patient's analgesia is patchy or it's a unilateral block. So Shilpa, what is the best way to deal with such a situation?
So again, this is not uncommon. This is very frequently seen in all the laboring wards. So firstly, the failure of existing satisfactory epidural is up to 20% for various reasons, which I will just come to. Then unsatisfactory labor epidural analgesia right from the beginning is again 9 to 27% in the literature. Now, again, causes can be operator related, technique related, or equipment or drug related. When you talk about operator related, it can be inadequate volume, which is given, or inadequate concentration of the drug, inappropriate position, or inadequate experience of the anesthetist, especially the non-obstetric anesthetist. If they are doing calls and they get a laboring patient, so they are not very comfortable doing obstetric labor epidurals. Another is technique. It can be a faulty technique, a difficult back or obese patients. We commonly see in these kind of patients. The third is equipment or drug failure, which can be a blocked catheter, loose connection, kinking, occlusion, or potency of the drug, or a wrong drug sometimes, which can be given. Now, again, broadly, the reasons of failure can be inadequate volume or concentration, incorrect needle placement, or the catheter placement. Sometimes it is working well and then it stops working is because of migration of the catheter, because you have not fixed it properly. So we should be very vigilant, and it's very prudent to have a good fixation of the epidural catheter. Then it can be altered anatomy, like a previous spine surgery. You normally see in these kind of patients because the epidural space is completely maybe fibrosed, septum are there, and the drug spread is not good enough. And you can see sacral sparing, especially when the baby's head is right at the perineum or in an occipito-posterior position. That gives a visceral pain, which is very difficult to deal with, even if your sensory level is at T6. So that particular perineal pain stays with occipito-posterior position of the fetus. And the third is a precipitous labor. Again, this has happened. A primary in within 45 minutes has become from 3 centimeters to 9 centimeters. So you have not got adequate time to troubleshoot this particular patient. So most important is early recognition of inadequate labor epidural analgesia. And so what I do, if there is a patchy block or a unilateral block, is first I talk to the patient. Now again, I'm not coming to everything Dr. Sanjay beautifully described about, communication with the patient. And it's not just going and giving the drug. A constant verbal communication, reassuring the patient is very patient's relatives also. That's very important. Okay, you build the mental strength of the patient, and before you insert, you actually, what we do is, because you've had enough, I mean, this is very interesting that once we had a patient, we gave an epidural and the patient had unilateral block. She delivered actually within 1 hour, 1.5 hours before we could even troubleshoot her unilateral block. And this particular patient refused to pay the bills for epidural placement of the hospital. Okay, and this was about 50, 60, 70,000 rupees. She said, I'm not going to pay. I didn't get a good pain relief, so I'm not going to pay the bills. So since then, again, with experience, you built up your institutional protocols and guidelines of the department. So we tell all the patients that this is a blind technique and there is a possibility of a patchy block or a unilateral block, and it is unpredictable. You may have it, you may not have it, and we may have to recite it. This is what we tell the patient. There are ways to troubleshoot, but we may have to recite it. And I'm sure this probably happens to everyone. Okay, so what I do is, first I keep talking to the patient. I assess the block, sensory as well as motor. I ask the patient, where exactly is your pain? Is it abdominal? Is it perineal? What is the type of pain? Is it continuous, or it is coming only with your contractions? Okay, then if I know that it is patchy or it is unilateral, then I give a bolus. My bolus is normally either 10 ml of 0.1% bupivacaine or 5 ml of 0.125% bupivacaine. And sometimes neither of it works. Then what I do, I give a 5 cc of 2% lignocaine actually to the patient, just to see if my epidural is actually in the correct space, working or not. And I tell the patient, you may feel a little numb at least for next 30 minutes to 45 minutes, but I need to assess whether I need to resite the catheter. Then if it is unilateral, then I change the position of the patient to the other side, at least for give a bolus in that position and wait for about 10-15 minutes. Generally it works. Or if that also doesn't work, then I withdraw the catheter by 1 centimeter and give a bolus and check. So all this takes about 45 minutes to an hour, because you're doing multiple interventions and you're waiting at least for 10-15 minutes for every intervention. And then I know if nothing is working, then I actually recite the catheter. This is what I do.
Just if I can add a point.
Absolutely, Dr. Sanjay, go ahead.
Actually, the trick is to share with the patient and the relatives to face a litigious crowd which is coming up slowly over the years. We don't use the word painless labor. We just say it is pain will be less. Nothing prevents us from giving her absolute good quality analgesia. But to be on the safer side, I think the communication part is also very important, because a patient shouldn't be coming in anticipating that there will be absolutely no pain.
Mm-hmm.
So here the importance of an informed consent, wherein you explain to the patient what all can go wrong. So that is very important when you're preparing the patient for the labor epidural, to tell the patient, explain that these are the problems that can go wrong with this technique, and how he or she can handle that, or the patient, or how we will handle it, and what the chances of complications with each. So if you have that in black and white, the chances of litigation decrease, and plus you get more cooperation for the patient as well, because they already they are accustomed to the possible complications or the shortcomings, and they tend to cooperate with you more. So key to this is good communication with the patient and the patient's relative, like Dr. Shilpa pointed out, because most of the times the relatives are also getting very anxious looking at the patient's pain or suffering. Yeah. So anybody else?
Ma'am, Srilata ma'am has joined back, and we have few questions in the chat box if we could address.
So can you read out the questions, because it's very difficult for me to listen to the panelists and read the questions at the same time. So you can So what I was told was that we will take the questions at the end. So that
We
is
will
why
take
I
at
thought-
the we will take
Yeah.
them at the end. Okay, ma'am.
Yeah, so it's better that way. Otherwise, the thought process is
Yes, ma'am.
interrupted, right?
Yes, ma'am.
So
Thank
that
you,
was
ma'am.
my opinion. So that's why we thought we'll take it at the end. So anybody else has any other ways of dealing with this unilateral blockade, especially? So I would also probably try changing the position, and also if that doesn't work, then withdrawing the catheter by increments of 1 centimeter till a minimum of at least 4 centimeters, 3 to 4 centimeters inside. If it's too much inside, you can afford to take out a little bit and give maybe a slightly higher dose of the local anesthetic, say 0.1 to 5 of bupivacaine, and look for adequate analgesia. If it's there, well and good. If not, then you decide to resite the catheter. Okay, so the third common problem is, what is your experience, Shilpa, with the fetal bradycardia during labor epidurals? And how do you handle that?
Yeah. So we, again, fetal bradycardia, we don't really see very frequently. Whenever we see fetal bradycardia now, you actually define it as if fetal heart rate is less than 110 for 110 or less for 10 minutes, or 100 for or less for 5 minutes. That is what you define as fetal bradycardia. So if you're talking about relation to anesthetist or labor epidurals, so one is we see if the patients, if you do a CSC or you give a single shot spinal, or if you give your loading dose of epidural really quickly, okay, that is the time. Like if you give it over just 3-4 minutes, your loading epidural, my loading dose is about 15 ml, which I give over 15 to 20 minutes because I don't use a test dose. So my every 2 to 3 ml bolus that I give of 0.1% levoanavin with 2 mics per cc of fentanyl goes over 15 to 20 minutes, and I keep talking to the patient. I keep writing the chart what I have done. So this is how I spend time with the patient. I know that it is not it's not going intrathecal, probably it's not intravascular, so you come to know. But if you do, if for whatever reason, if you get maternal blood pressure of 100, 90 or 80, which stays for about 5 minutes also, then there is fetal bradycardia that you normally observe. And these patients are also on oxytocin augmentation. So my first thing, I stop the oxytocin drip. I give a normal drip, normal RL. I give it fast. I start it. Then I ask the patient to move to left lateral position. I start oxygen on the patient, and we keep monitoring the fetal heart rate. And if there is a epidural which is going continuous drip, that also we stop. Okay, then there is something called as rule of 3 in fetal bradycardia. If it stays for 3 minutes, you call for help. If it stays for another 3 minutes, you inform the OT or move the patient to OT. If it stays for another 3 minutes, you prepare the patient for delivery. This is a rule of 3 for fetal bradycardia.
So do you find the fetal bradycardia more with the CSC versus plain epidural?
Yes, it is more seen with CSC versus plain epidural because it kicks in very fast, and the catecholamine surge which the patient had been having due to labor pain is suddenly taken away.
So is your obstetrician more biased towards not giving CSC, or do the obstetricians prefer a labor epidural because of the
yes, they do prefer labor epidural over CSC, because in the audit that we did of our hospital, we saw that most of the fetal, like 90% of the fetal bradycardias have happened only when the CSC was
during
done.
CSCs.
Yeah.
So I have the same experience too. So that is why you get a kind of feedback from the obstetricians that they are not comfortable with us giving CSCs.
Correct.
Vis-a-vis simple epidurals.
Yeah, it just takes another 5-10 minutes to kick in. So only epidurals are better that way.
Right. So while you were mentioning that test dose, I think I skipped asking Kausalya this question. Kausalya, what is the status of giving a test dose before initiating a labor epidural, and what are the various ways of giving a test dose?
Yeah, conventional test dose is actually it's xylocaine with epinephrine, adrenaline. So actually, a conventional test dose means 15 milligrams to 45 to 60 milligrams of xylocaine and 15 micrograms of adrenaline. But in labor epidural, when we are giving xylocaine with adrenaline, what is happening is this is actually to rule out the intravascular and the intrathecal placement. So when we are giving so much of drug, that means we have not got any CSF, or we have not got any blood tap, and we are giving a test dose to rule out this occult CSF and occult blood tap. But then if this test dose is going inside the subdural space, what they have found is the drug is ascending more in parturient than in the non-pregnant patients. So it is causing more amount of maternal hypotension, and it is not ruling out the either intrathecal placement or the intravascular placement. So the xylocaine, they are not comfortable with xylocaine. And coming to adrenaline, the adrenaline increases the maternal heart rate by about 10 beats per minute. But then if you have to give xylocaine with adrenaline, you have to time your dosage of the test dose so that you are giving it in between the contractions. Because when you give it along with the contractions, this can get confused whether the patient is having the tachycardia because of the intravascular placement or because of the contraction itself. So ultimately, what the literature says is, instead of going for the conventional test dose of 2% xylocaine with or 1.5% xylocaine with adrenaline, you can use every low dose mixture as a test dose. So you can give 5 ml of the low dose mixture and wait for 5 minutes and see whether the patient is having adequate pain relief or not. And if the patient is having adequate pain relief, that means it is not, it is the epidural catheter is in place. And if it is not in adequate, if it is in the intrathecal compartment, then it will definitely cause little amount of the motor block, even though it is ropivacaine or a bupivacaine. So the dictum is ultimately every dose should be a test dose, and you can use the same low dose mixture as the test dose.
Absolutely, Kausalya. I think most of us are practicing the same technique of using the epidural mixture itself as a test dose. So every time you give a top up, you treat it as a test dose, right? So moving on to the next scenario where, so most cardiac disease is something that we very frequently encounter in pregnancy. And sometimes you have patients who have cardiac disease, and these are the subset of patients where actually labor analgesia is very beneficial. So what would be the technique of choice for such patients, especially who have severe cardiac disease like severe MS? So, Dr. Sanjay, what would be your technique of choice? And what do you think of a vaginal cardiac delivery? You know, a patient with cardiac disease who requires labor analgesia.
So basically what happens is the WHO has actually classified the patients in labor upon the cardiac risk. So they have divided into, firstly, if there is no risk, additional risk to the patient. Then if there is a mild risk is level 2, level 3 is mild to moderate risk, and level 4 and 5 basically where any labor is actually best avoided. So that is the WHO classification. And obviously based upon the specific cardiac disease, the drugs have to be modified. We have to take care of the preload or afterload depending on what sort of a lesion it is. But there are some things which is absolute in the sense that the titration of the epidural dose has to be very, very slow and gradually titrated. So that we have to be very, very specific. There are specific advantages because if we are able to abolish the pain of labor, because what is said in obstetrics is cesarean should not be indicated except for obstetric reasons. So normal labor is the way forward. And if normal labor proceeds, what the anesthesiologist is responsible for is to obviously decrease the stress of labor and the catecholamine release, which happens due to the pain. So the best way to do that is obviously a neuraxial anesthesia. What we do is basically use a slightly lower concentration of the analgesia that we are using. So if mostly we use 0.1 to 0.125 opioid, we drop it down to 0.0625. And that is how it is to be done. We just discussed the epidural test dose, and we are rightfully, most of us are avoiding a xylocaine with adrenaline 1:2 lakh in laboring patients. So that is the way forward, because One thing is there 2-3 things can happen. One is it's an intravascular placement of the catheter. So if we give say 50 to 100 microgram of fentanyl to that, the impact of the opioid will be very obvious to the patient, at least in most of the cases. So we can find out whether it's a intravenous injection which has happened of the drug. Second is obviously now we have these multi-pore catheters. So a negative aspiration through these multi-pore catheters is nearly 90% of utility in telling that whether it is in an intravascular space or not. So that gives us an additional layer of comfort. And third, as we just said, that just giving continuous low doses as a trial dose and see whether it works or not, that is the best way forward. Obviously, there are specific cases where the preload has to be minimized or the SVR has to be decreased. So based upon that. And second part of it, obviously, use of oxytocin. In all such patients, it has to be minimal dose and as low as possible. Argometrin and prostaglandins are best avoided. Prostaglandins, especially in patients who have a pulmonary hypertension to say.
So the important thing here to summarize is to first be very careful about the local anesthetic that you are using, careful titration. So the aim is to prevent hypertension of any kind and careful monitoring. I think that is one of the most important things. The patient's ECG, blood pressure and pulse oximetry should be continuously on and carefully monitored, preferably by an anesthesia resident. If not, a well-trained labor room nurse should be there around the clock with the patient. And also probably in a patient who has a more severe cardiac disease and you want to cut down on the, go down on your local anesthetic concentration, then I would probably use a CSC technique and give opioid only intrathecal dose. It may say maybe 12.5 to 25, even 25 microgram of fentanyl intrathecally without any local anesthetic, so that you can cut down on the local anesthetic in the epidural. So I would probably kind of practice that. Any other ideas, Shilpa? You'll have to unmute yourself, Shilpa.
I would do exactly what Dr. Sanjay and you just mentioned. You have to be really careful about maintaining the hemodynamics of the patient, not increasing the preload, afterload. That's the safety comes first. And ensure a good working epidural so that the surge of catecholamines because of labor pain also compromises the cardiac function, so that doesn't happen.
So what is your opinion on just giving intrathecal opioid? Do you practice that?
No, we don't actually. What I do in our loading dose of epidural, we add 50 to sometimes even 100 micrograms of fentanyl. Yeah, so that is good enough. Otherwise, with 25 micrograms of intrathecal fentanyl also, we see a lot of pruritus.
So that is definitely side effect of intrathecal opioids. Pruritus, I think that can be very annoying.
25 micrograms of intrathecal opioid is a little bit more, especially in cardiac conditions. 15 micrograms will suffice, because if you give 25 micrograms and suddenly the catecholamine levels come down, because of this, the uterus will lose the tocolytic effect and it can cause tonic contractions of the uterus. Again, that will cause fetal bradycardia.
Yes, yeah, that could be one of the reasons for fetal bradycardia. But when you are dealing with a severe MS where you don't want to kind of go down on the cardiac output, then even 25 microgram, I've given 25 microgram also in certain cases, because it has a very good analgesic effect. So the sympathetic activity is completely, taken care of. So all the detrimental effects of increased sympathetic activity is abolished. So probably 12.5 to 20 microgram, depending on the patient's need or the patient's underlying condition, would be a good dose to go ahead with. And obviously in the epidural, a very low concentration of local anesthetic and close monitoring of the vital signs. Okay, so coming to the next, I think probably the last case scenario, and this is for Dr. Samina. Now you have a 28-year-old primary gravida at 37 weeks of gestation who presents with rupture of membranes and painful contractions. And she has been taking low molecular weight heparin twice daily for a history of deep venous thrombosis. and her last dose of enoxaparin was about 2 hours ago. So in such a patient where obviously the neuraxial analgesia is contraindicated, what are the alternative techniques of analgesia that you can offer to this participant?
Good evening, everyone. There has been an exhaustive discussion on neuraxial analgesia, which is considered as gold standard for patients in labor. But unfortunately, this patient, we cannot give this neuraxial analgesia because she's on anticoagulants, and in view of the deranged coagulation profile, we have to offer her non-neuraxial techniques of analgesia. We have many options for this patient, but before we offer her any type of analgesia, the first thing is that we need to counsel her. The counseling part is very important if we are giving non-neuraxial analgesia, because maybe the patient has herself requested for the labor analgesia, and if she cannot expect a complete or near complete pain relief, which is possible with epidurals. So counseling is the first thing. Second thing is that maybe even with epidurals, we require accompanying birthing companion. So this is also must for these patients, because if she has her husband or her mother or any other close relative with her, maybe this will help in allaying the anxiety, and which itself will help her in coping up with the labor pains. Now we have, after these two things, I think we have many options, but I will be only talking about the ones which are within the scope of our expertise and within the scope of most of the setups. We have a number of non-pharmacological as well as pharmacological techniques. One is the inhalational agents which can be used. These are safest, and we use Entonox in most of the cases. And I think Entonox is a very safe agent. It is a pre-mixed mixture of oxygen and nitrous oxide. Nitrous oxide 50% and oxygen 50%. And it is very safe for labor patients because it's because of its properties of it being odorless and tasteless. And the other benefit of nitrous oxide or Entonox is that it can be used in all three stages of labor, during first stage, second stage, and even after the post-delivery procedures, we can use this. And although the patients may not have complete pain relief, most of them are very satisfied with this. It has to be delivered through, and there is a system. There are prefixed Entonox, pre-filled Entonox cylinders are available, and the patient can inhale them through the mask themselves. They can inhale it whenever they are having pain, and there is a demand valve placed in this delivery system, and it is recommended that scavenging systems should be in place if the labor units are using Entonox regularly, to avoid OT pollution and to avoid the exposure of the healthcare personnel around taking care of the patients. This is the first thing. And we have to keep in mind certain contraindications even for nitrous oxide, because as this, if patient is having any condition in which there is impaired consciousness, or if she has undergone any eye or ear surgeries, or if she is a cardiac patient with severe pulmonary hypertension, then I think Entonox is not advisable in such type of patients. The benefit of this is, another benefit of this is that the patient has a sense of self-control over the agent which she is taking for labor pain, but we need to train her for that. The action begins within 30 seconds of inhalation of Entonox. So the parturient should be trained to inhale the gas whenever she has onset of the uterine contractions. The good thing about nitrous oxide is that it does not have any detrimental effect on uterine physiology. as well as there are no negative effects on the fetus or the neonate. Then we have, besides Entonox, one more thing about Entonox is that it can be combined with other techniques of labor analgesia also. Then we have, now this was one thing. Some centers are also combining inhalational agents like sevoflurane 0.8%. Then we have systemic opioids. A large number of opioids are available, but I think the best opioid, fentanyl. Again, remifentanyl's availability and cost could be a factor for it to be used regularly as an agent for labor analgesia. If it is available, it is a very good agent. It is ultra short acting. Its metabolism is through plasma. This, I think, if we are giving intermittent boluses or infusion,
I think Samina probably has a problem with the internet connection. So meanwhile, I see one question in the chat box where someone is asking our experience with TENS for labor analgesia.
Disconnected. I'm back.
Sorry, Samina.
Should I continue?
Yeah, you can switch off your video if your internet connection is unstable. You can switch off your video and just
unfortunately it just got disconnected. Should I continue or
yeah, please continue, but you can switch off your video, Samina. You can switch. Yeah. So you can continue. Hello, Samina. So, like I was asking, Tanvir, I think we can take that question.
Yes, ma'am.
Yeah. So, I was asking about the panelists' experience with TENS. Is anyone using TENS as a modality for labor analgesia?
We have actually TENS, but then we use TENS in few patients. It gives a little amount of distraction to the patient, but it doesn't give that much amount of pain relief. Ultimately, the patient will get more irritated by TENS. And instead of giving TENS, I feel nitrous or Entonox is much better.
Absolutely. I also feel that Entonox provides very good analgesia where, non-neuralgial analgesia techniques are concerned. So this is a very good option. But if you don't have Entonox, there are many centers who are routinely using TENS as a labor analgesia technique, and they have published good results with that as well. So I have no experience with TENS, so I just wanted to know other panelists' opinion on this. Dr. Sanjay, do you use TENS?
No, ma'am. Very little experience with TENS.
Okay. So Shilpa has already said that all their patients get labor epidural, so she obviously has no experience with TENS. So
I would like to share one experience of no, not TENS.
Okay.
We don't even have TENS, and
sure, yeah.
I personally don't believe in TENS for
Absolutely,
labor epidural. It's okay for physiotherapists who use it for some other kind of pain relief or some sacral pain.
Yeah.
So once we had, so I'll just take 2 minutes. I know you're getting delayed.
No problem. We have Dr. Bharti also here. So go on.
Okay.
Go on.
So once we had a primee who was 3 centimeters dilated. I was in the OT and I was told that this patient is the daughter of a dean of a big hospital. So she was very well aware of epidural, very well read. Her mother was also there, who was a doctor and dean, so they have that air around them and they expect a lot from you. So I must have taken maximum like 5-6 minutes to go to the labor floor. And suddenly she said, I'm having a potty pressure. So I told the obstetricians, just why don't you just do her PV, because I think she's quite advanced in labor. Surprisingly, she was fully dilated. Okay, so this was like less than half an hour, she was fully dilated, primary. So this particular patient wanted actually a water birth. So there was a separate, we prepared a water bath for her, and we got all those, everything that you need for it, a big tub with water and the temperature of the water. But there was no time.
Short notice? On such short notice?
No, it was planned that she wanted a water birth. So for her obstetrician had arranged. We normally don't have it, but they had arranged from somewhere. But there was no time to get into that water bath also. So I told her, I will use Antonox for you. Now she knew what is Antonox. She knew that nitrous is a laughing gas. So we have a proper non-rebreathing valve, which we ordered from UK, because I don't know where it is available in India. So, and we told her how to use it. So as soon as I said, you have a tightness, you hold it, take 2-3 breaths. And it is only when you breathe, the nitrous Antonox gas is released, and you get that noise also. So she used it appropriately. She got fantastic pain relief, and she actually was continuously laughing and talking to us. She said, you know what? I know I'm using nitrous, and I know I am hilarious, and I know I am very happy about it. And I don't know why I'm behaving that way. It was the best example of nitrous that I have ever seen in my life. So if appropriately used, nitrous is really good.
Really good. That's true.
If used
except that now that we are getting environmentally conscious, it contributes a lot to the greenhouse gases.
So we don't use it for last
20
years. We've not used it in the OT at all, but only for this we use Antonox for such kind of
exceptional conditions. Yes, absolutely.
Yes.
Okay. So our panel discussion cannot be complete if we don't ask the opinion of Dr. Bharti Kalra, who's a practicing obstetrician. And Dr. Bharti, I would like to ask you, what is your concerns as an obstetrician regarding two things? First, the implication of epidural analgesia on the outcome of labor, and secondly, the health of both the mother and the baby, because the parturient is basically your patient. So what are your ideas or views on the labor epidural regarding these aspects?
First of all, I thank you for inviting me for this very learned people's session. I am enjoying it a lot. Being an obstetrician and being into practice, I just want to put a few points from obstetrician's point of view. Because I know here madam is there who has done gynae practice, as well as she is into this anesthesia. She might have liked anesthesia more than obstetrician's life. So she has changed her way to the anesthetist. Anyway, because the obstetricians are usually busy with their OPDs, so to making their patients aware, I just see the example of my today's patient. Patients, if you put on the boards you put in your OPD that this facility is available with you, labor analgesia facility is available with you. In waiting time, patients read about it and they come and ask from you. So that is just a proactively patient is asking about the labor analgesia from you, that how will her labor experience be like. And another thing is you impart the information to them and we make them knowledgeable. So we tell them, because we put it in our waiting area and we tell them you just read about it, and then if you have some level of information, then we will discuss about it. So the obstetricians play a very important role in making all this scenario to happen, and labor and delivery being a very pleasant experience for our patients. So this is the positive aspect. And in our OPD, we being the first person of contact for the patients, we tell them that these are the positive aspects of this, and we assess them whether they are suitable for labor analgesia or not. And then we book the appointment with the anesthetist, because here being a small place, we have visiting anesthetists. They have freelancing facilities. So they come and assess the patient. And here they prefer the daytime delivery for that patient because they are bound to the patient. So for these patients, if we need induction of labor, then we start it in the morning. And so that the patient delivers in the daytime only. So these are the practical aspects of being an obstetrician and providing labor analgesia to our patients. And as far as the fetal and maternal concerns are there, because it is very widely discussed whether it is harmful or whether it is causing increase in the cesarean rate or the instrumental delivery. Earlier, the drugs used, we have seen the patients who had problems with the instrumental delivery or who were not able to push and the baby landed up in fetal distress, or those with started with labor analgesia and it became labor anesthesia and landed up in cesarean. So, but now as all the drugs are safe and the minimum quantity is used, ambulatory labor analgesia facilities are there. So this risk has reduced drastically. Although it is reduced, but we should know that everything has a few of it, even if it is 0.1% of any complication, but we have to make patient aware of it and we have to take consent for that. And as far as the fetal distress is widely discussed in today's session, and that problem is there because we have to keep such patients in continuous monitoring in labor room. We can't keep them in their rooms, and we have to call one attendant with them so that to give them support, and continuous fetal monitoring is to be done. So if there is, because our threshold is very low for any complication. Obstetricians means you may be saying that it's a panic button, they will switch the panic button very fast, but it is there because we are very much worried to give the best outcome to our patient, and our patient should carry a healthy baby in her lap. So these are the main concerns. Otherwise, the practical problems are there because obstetrician is bound to such patients, those who are taking labor analgesia, anesthetist, obstetrician, and the trained staff. Not like that, we just leave it to our staff and they will monitor. We have to be around with them. So that is a time consuming, but ultimately if patient gets pleasant experience, that gives us happiness also.
Thank you, Dr. Bharti, for that excellent feedback. And I think we've kind of covered more or less almost all the practical aspects. Any of the panelists want to add anything else that we haven't discussed?
I had some network issues, so I couldn't speak all my points completely. So should I allow to tell the remaining things, or should I wait for further discussion?
So Meena, your voice is still breaking up. It's not very clear.
Ma'am, should I speak the remaining things or should I wait?
Let me see if there are any questions regarding the non-neuraxial anesthesia technique, Samina, then I'll direct it towards you. Okay, so
because there were a lot of questions in the chat box regarding the use of different agents in low resource settings. I had seen some questions also.
Yeah, absolutely.
I had not covered the fentanyl part. Yeah.
Okay.
So and I had not covered my talk about fentanyl also. I would just like to highlight some things about fentanyl if it is being used for uraxial and non-uraxial labor analgesia. Fentanyl is a very potent opioid, and if we are using it for labor analgesia, we have to keep in mind that it should not be given during the second stage of labor, as it can have it can cause neonatal depression if we use it for second stage. If the patient is on PCA with fentanyl or if on infusion, then with the onset of second stage, the infusion or the top-ups should stop, and the rest of the thing can be managed with other alternative methods. And I think the duration of fentanyl is such that if we stop at the onset of second stage, the things can be manageable with that also. Then we have options like trans-electrical nerve stimulation, and this is a non-pharmacological method. It works on the principle of gate theory of pain. Low voltage electrical impulses are transmitted through the electrodes applied on the lower part of the back near the vertebral levels. These electrodes, these are like the patient herself can control the intensity with the help of the handhelds. And since low voltage frequency impulses are getting transmitted through the nerves, so full stimuli from the uterine contractions are inhibited. So this can be a useful adjunct One thing I would like to tell about TENS is that if they are using it for management, certain contraindications should be kept in mind, such as if the patient is on pacemaker, then this device is not advisable. If patient is having history of convulsions, then also we should keep in mind that there be close monitoring of the patient, because if in case there occurs convulsion or seizure during the use of this TENS, then there can be a change in the frequency and impulse that can cause damage to the skin. So if we keep all these things in mind, I think the combination of different pharmacological and non-pharmacological methods, even if patient is not fit for neuraxial techniques, we can successfully manage the patient with this few techniques. There were some questions in chat box. But
we'll get
even
to them
Madam, ketamine has also been used for labor analgesia in low doses with good results.
Thank you so much, Samina. Thank you. Yeah.
Thank you.
So there are a couple of questions for Shilpa regarding the accidental dural puncture. There's a question about what length to thread in the catheter in the intrathecal space.
So in the intrathecal space, normally we keep about 3 centimeters.
Right. So about 3 centimeters is more than enough, not more than that, because that can cause nerve injury. So what drug to use? The next question is preservative-free bupivacaine, ropivacaine vial, or hyperbaric drugs?
So ideally, preservative-free is ideal to use, because phenylparabene, which is a preservative, is neurotoxic. So you should go for a preservative-free drug.
Okay, so would you prefer isobaric bupivacaine vial or hyperbaric bupivacaine for intrathecal administration?
So you can, it depends on what you have. Whatever, I would prefer isobaric, but if you have hyperbaric, you can use that, or you can use isobaric. It all depends on how, you should know how to manage both. Hyperbaric with gravity and isobaric will have propensity for capillate spread.
So Dr. Sanjay, there's one question for you for the management of accidental dural puncture. They want to know what is, if you want to resite the catheter, epidural catheter, should it be above or below the first puncture site? Say you have an accidental dural puncture and you want to resite the epidural. So will you do it above the previous puncture or below it?
So obviously it depends upon where the first puncture is. And if it is a L3, L4, possibly we do it one side above it, because it may be difficult getting it one side lower. But I think depending upon where you site the catheter, then obviously the dose of the drug and subsequent actions will depend upon it. But because we are using isobaric drugs, so that is why the spread will depend upon the volume.
Okay, so there is one question on the use of intrathecal buprenorphine. So does any of the panelists have any experience on using buprenorphine intrathecally for labor analgesia?
Actually,
I personally have not used it. So Shilpa, have you used it? Buprenorphine?
I have never used it, and I will never advocate the use of intrathecal buprenorphine, because first of all, it is not FDA approved for use, intrathecal use. Secondly, especially in obstetrics, you don't have an antidote for buprenorphine. Naloxone is an antidote for fentanyl and morphine, but you don't have an antidote for buprenorphine. And medical legally, nobody can save you if the patient lands up with a respiratory depression and then respiratory arrest. So we don't advocate in obstetric anesthesia at all. I don't know what Kaushalya has to say. Kaushalya, do you have any different opinion?
We don't use buprenorphine for labor epidurals, and even otherwise, buprenorphine causes more amount of nausea and vomiting. But definitely, there are certain studies where they have used buprenorphine for labor epidural, but we don't use buprenorphine. As you said, it cannot be antagonized easily, and though we have antagonists, when we give the intrathecal dose, it cannot be antagonized that fast. And buprenorphine is not all that approved for labor epidurals.
That's
So
true.
and clonidine also. There are
So-
many studies on clonidine also, but clonidine
Yeah.
causes too much of fetal bradycardia.
Absolutely. So as an adjuvant, I think the only thing which is well researched and advocated is opioids.
Yeah.
All other adjuvants have been studied, but it's not recommended to use because all of them have a lot of side effects.
Yeah.
So
I mean-
opioids are in fact associated with least side effects.
In fact,
Fentanyl and
what-
sufentanil. Sorry?
yeah, what we have seen, ma'am, in early 2000s, nearly every drug in the anesthetus armamentarium has been deposited in the intrathecal and
intrathecal
epidural space.
Absolutely.
Actually, with now so safe literature available and safety and literature available on its safety, I don't think there is much scope for experimentation. But the point here is many of the times in rural areas, these pure narcotics, because of the licensing issues, are often not available. So
Yeah.
that is why many of us working in these low resource settings try using them. But as you rightly said, I think this is a safety of 2 lives at stake. It is
Absolutely.
better to be safe in these.
Avoid using the fentanyl.
Yeah.
Absolutely.
Fentanyl is available nowadays. Even in rural areas, we are getting fentanyl.
Fentanyl. Yeah.
Fentanyl is easily available.
Okay.
Yeah.
So another question for you, Shilpa. Adequate analgesia is achieved, but patient complaining of continuous pain in one thigh. What can be the possibilities and remedies?
Again, that means it's a patchy block. One particular segment is not blocked adequately because the spread of the local anesthetic in that particular nerve segment has not reached. So my troubleshooting will remain the same. So same thing. So I will try to give if it is right side thigh, I will turn the patient to right lateral and give a bolus dose of maybe 10 ml of 0.1% after checking the sensory level. And then I may withdraw the catheter by 1 centimeter and give another bolus of 5 ml of the low dose solution and check if it is working or not. If nothing is working and if this is bothering her too much, then I recite it.
Yes.
But thigh is okay. I think thigh is okay.
It's an unusual site for pain actually, labor pain.
I think that person who has asked must have experienced
encountered, absolutely. Must have had
so
a
you should tell the
personal
patient ki thigh pain is okay, doesn't matter. Just your counseling also matters, how you know.
But you can surely try what Dr. Shilpa has advocated. You can try turning the patient on that side and giving an additional dose of local anesthetic. So there is another question where the person did not find any CSF on aspiration through the epidural catheter, but later on, after giving the drug, the patient had numbness in both the upper limbs.
Subdural.
I'm not sure.
Yeah, this is typical of subdural presentation.
Yeah.
Actually.
Absolutely. Yeah.
So subdural is deeper to epidural and not reach the intrathecal, and it's absolutely flattened space. Even a small drug will give a patchy block and inadequate block. Patient may have tingling in the upper limbs, may have tinnitus also.
Tinnitus. And also hypotension. Patient will also have hypotension, especially if you've given a larger dose. Yeah.
So if you have seen one subdural, you'll not forget it for your lifetime.
Ever. That's true. So that is typical presentation of a subdural placement of the epidural catheter. Okay, then another question is the role of ultrasound guided epidural in labor analgesia.
Excellent. It's very good.
So Kaushalya, what is your take in it?
Yes, we don't routinely use ultrasound for labor epidurals, madam. But then if the patient is really tough epidural, we definitely use a ultrasound, especially in obese patients where we go for an ultrasound, and ultrasound has to be brought to the labor ward, and it has to be almost like a real time in the same position of the patient, and we have to see this one, and better to go for a CSC instead of going for a plain epidural so that we are sure about the procedure.
Absolutely, I agree with you. And I think if you are experienced or well conversed with the use of ultrasound in a normal patient, then only you should practice the use of ultrasound in an obstetric patient. And
Vimi
even
ma'am,
if you...
Vimi ma'am, one question shall I ask?
Yeah, sure.
It's just like, unlearning and new learning. I see labor analgesia being practiced by the practitioners in majority of the centers where ultrasound is not there. Now, with this discussion, if we say that ultrasound is superior to the blind procedure or the whatever the air or resistance method, water resistance method, saline resistance method we are using in the peripheries, if we are imposing something on the practitioner that you should go for the ultrasound training to make it more safe, where we cannot provide them ultrasound for the next 50 to 100 years, because the deliveries are not going to stop. They are going to help there. They are going to be happening and making them, somewhere guilty in their heart that ultrasound is much, much better in providing a labor epidural or any procedure wherever the safety is concerned. That means we are taking up the many rural health services, many peripheral health services from the vicinity of those areas. I think this is a very, very valid question in the current where PNDT Act is also very in vogue. You cannot take ultrasound from one room to another room. So I think this is a very delicate point here to make somebody learn ultrasound forcibly to unlearn the procedure which he has acquired over the years, and he is master than that. He can put epidural within 2 to 3 minutes, rather than I've seen people putting epidural in 15 to 20 minutes by using ultrasound. I've seen those people also. So it is just have to be a balanced approach, I think, here.
No, I didn't get your point, Dr. Bajwa.
Actually,
sorry,
I would like to make a
it.
statement. The point here is not replacing the ultrasound guided placement of epidural. You can't do it because it is not real time. As Kaushalya rightly said, only in very obese patients with high BMI who have very crooked back, some kyphoscoliosis, where you cannot even feel the midline, it is only a guide. But ultimately, you're using a blind technique, either loss of resistance to air or saline. So you cannot replace ultrasound guided placement of epidural with the conventional placement of epidural any which ways.
Yes, absolutely. So this is actually reserved for only difficult patients where spine is not palpable. Sometimes you get very obese patients where you have absolutely no palpation of the spinous processes and you have no idea where to go. So just to localize the entry point, I think epidural can be useful if you have it. But if you don't and you have enough experience in placing epidurals in obese patients as well, then that's very good. We are not advocating as a panel for routine use of ultrasound, absolutely not. But you have an extra expertise in using ultrasound for placing neuraxial blocks, then obviously it's an asset. And in difficult epidurals, it can help the patient, both the anesthesiologist as well as the patient. So absolutely not, it's not mandatory to use ultrasound. That is not what we are advocating.
The message should be clear. From the discussion, the message absolutely should be clear enough to everyone.
Yeah. Yes, absolutely. I agree. So what is the rationale behind making the patient sit in the later stage of labor after initiation of epidural who complains of pain, since we are using isobaric drugs mostly?
Indeed.
Dr. Sanjay?
Yeah, ma'am. Basically, what we have seen and what there is little literature evidence, if the patient is ambulating, there is some evidence to say that the instrumental deliveries and cesarean rates are slightly lower. But again, we need much larger studies to prove this. But the walking epidurals, the concept of it, theoretically says that if the patient is mobile, possibly the duration of labor and instrumental deliveries can be brought down. But again, that comes in with a caveat. The patient should not be allowed to mobilize without somebody with her to support while she is moving.
Shall we add something more here?
Yes,
please, sir.
Little bit selfish on this side. I think the stages at which the patient really wants a labor epidural depends upon the choice of the patient, depends upon the assessment by the obstetrician, and also depends upon the perception of pain, how much the threshold patient can bear. Whatever in the settings we have been giving epidural, labor epidural, when the patient experiences pain, now I'm a little selfish, when the patient experiences pain, at that time, the patient really wants to get relief of it. And when the anesthesiologist institutes an epidural, the relief the patient gets, the status of the anesthesiologist rises so much higher level at that time as compared to obstetrician attending that patient. That is one. Second is regarding the instrumental delivery, everything, when the patient is having pain, that means all the musculature, the pelvic musculature is compressing the lungs. is compressing the baby as a whole. The circulation is intact. The lungs are getting, basically ready for the delivery, for the vaginal delivery. I think that is the best stage, rather than putting in the earlier stages where the patient doesn't experience his pain. And when the patient start experiencing pain, she may not be able to push down the efforts. I think Dr. Bharti is the best person to answer at this stage if the doubt remains in the patient's mind. Ma'am, Dr. Bharti, I want your inputs. This is a very sensitive question.
So for this, because we have to be around the patient and counsel her to bear down, because I think you are asking about bearing down. Na? Patient will not be able to bear down.
Yeah, if you give it in earlier stages.
It is because earlier it was that it should be given after 4 centimeters. So we used to tell patient that you just wait, let us dilate, your cervix should dilate.
In the primary, you are talking in the primary or the multi-gravida?
Yes, primary, because multis progress very fast.
Yeah.
And multis have already experienced, so they progress very fast.
Yeah.
And they start pushing down. Even if they are given epidural, and they start pushing down because they know how to do it. So that is not affected.
So primaries are basically, ma'am, inexperienced patients. Sometimes
Yes.
even they may not be able to cooperate. Sometimes
Yes.
getting a relief from the pain, they start not cooperating with you. They start not bearing down. This is the problem we face every day when we give labor.
This is a practical problem because we don't feel any pain. What should we do?
Why should
Because
we
they
do?
don't know. Even if we tell them breathing exercises and tell them when to bear down, how to bear down, they may not be cooperative for that also.
Thank
So
you.
I have a little different opinion here. Actually, patient's request is sufficient indication to place an epidural.
Yes.
And this is what we have been following. We have very frequently placed epidural when the patient, like a primary, is only 1 centimeter and is in severe pain, because every patient is different. Every patient's pain threshold is different. Every labor is different. For the same patient, first labor is different than the second labor. So when the patient asks for it, we provide it. And because now we are using ultra low dose, I don't see, and they're all educated patients now, or if they are not educated, you educate the patient. We tell them we will give you 85 to 90% of pain relief. So the pain that you will feel now is not pain, but tightness in your abdomen. That is how your contraction will be felt. And they know that what tightness is. And they know that now the contraction has come. And then you help them to, you just tell them to push, like you push very hard stools. And that is what we normally do. And we never had problems. We never wait for 4 centimeters or 5 centimeters. We never delay placing an epidural catheter.
And we also ask them to place their hand on their uterus and feel for it. Yeah. So, and you bear down along with that. Since they're not having that pain, so that feeling of the uterus contracting is a very good guide to a uterine contraction.
Ma'am, in my that one point, I made it first thing that patients indicates the patient indication when the patient demands it. We are dealing in the patients who are maybe educated 10th class, plus 2 class. I think whatever the variety of the patients coming from villages. Now villages people also, they want painless delivery. And I think their perception of pain is much, much higher. The threshold is much higher as compared to the ladies from the cities. Now, during this epidural administration, what the most help the person providing you is the obstetrician. The way you and obstetrician stand together and counsel the patient, the results achieved are much, much satisfactory. We have placed epidural even without I think when the patient we are inducing with the oxytocin in the bottle, we have placed epidural at that time also, so that the catheter should be there. As soon as the pain starts, we will give the doses. That is the ease of the anesthesiologist. Patient positioning is very good during that stages. During pain, the patient positioning is also difficult. But overall, what I think the success of any epidural, labor epidural, I've never given any labor epidural without the absence of obstetrician standing there. That's the best way, because the patient feels that their obstetrician is standing with them. She is managing them also. It's not an anesthetist. I think this is a very, very healthy atmosphere if you create that type of scene in the whatever you call even the injection room where you are administering the labor epidural. That's the best way we can have a cordial atmosphere also.
Dr. Bajwa, there's one question for you.
Yeah,
the question is, what is the ideal alternate drug for fentanyl, which you think is easily available even in periphery?
Ma'am, I'm using buterfenol absolute excellent results with the butadol. Butadol comes, or any brand of butyrophenol you use, it's absolutely safe, easily available. Lot of studies. There is no problem with that. It's easily available to anybody in the periphery.
What is the dose that needs to be used?
Madam, I basically give in around 2 microgram only. That is good enough. 2 to 3 microgram are good enough in the epidural space. That provides you relief of almost 3 to 4 hours. With the ropivacaine, I'm using ropivacaine. And now with the levobupivacaine also available, you can use that also.
Okay, so another question for Dr. Kausalya. Is the epidural test dose of lignocaine plus adrenaline the recommendation of not using it, is it an ACOG ASA guideline, or is it a guideline which is its general recommendation based on the literature that is available?
ACOG and RCOG also, they are not commenting on the use of epidural test dose as such, but then the literature says that there is no advantage of using an epidural test dose. Actually, there are certain studies which say that because of the epidural test dose, the mother has gone into hypotension, hypoxia, fetal bradycardia, and all these effects. So they have attributed all these things to the epidural test dose. In fact, I have used epidural test dose in almost all the cases of labor epidurals, which I have been using almost till the last decade. So I never faced any complication with the test dose. But then when I am talking on a podium, I have to tell you what the literature says and what everybody does. If you are comfortable with giving a test dose, yes, you can carry on. But then limit the amount of the test dose that you are giving to 1 or 2 cc instead of giving the entire 45 to 60 milligrams. Otherwise, just make it a habit to leave the test dose when you are giving labor epidurals. I'm not asking you to skip the test dose when you are giving for the surgical procedure, when you are taking the patient for the cesarean section. Because in labor epidural, there is no added advantage of using a test dose. You can skip it as well.
Thank you, Kausalya. That was an excellent answer to the question.
Dose was 0.2 to 0.3 milligram, not microgram.
Sorry.
0.2 to 0.3 milligram.
Milligram, okay.
Yeah.
Okay. Yeah, so.
Beautiful.
Ma'am, tell me, I think from the house, one should we ask how many of our anesthesiologists really do with the obstetrician or gynecologist standing there? Are they comfortable? I think it's a very open question. Are they comfortable with the obstetrician and gynecologist standing when they are administering the epidural, labor epidural, and coordinated counseling? I think that's very important. That's why the idea of Dr. Bharti having here is, I think it has come up for that thing.
Sir, we always do with the obstetrician by the side.
I'm talking about the periphery also. There are the practice. It's open to every house. I think everybody can say they are not comfortable. They can write here. This is a very practical question, actually, ma'am.
Okay, but I always have the obstetrician by my side when I'm doing even while I'm counseling the patient, the obstetrician will be there. Because, you know, the obstetricians, they deal with the patients for 9 months. We see them only for 9 hours. So
and they are mentally, ma'am, they are mentally prepared to deal with their patient's mentality rather than us.
Okay, I think that more or less answers all the questions. Have I skipped any of the questions, Tanveer and?
One was regarding the dural puncture epidural advantages, disadvantages, and is it beneficial?
Dr. Dev, what is I think he's answered all that question,
yeah,
but he can repeat it.
Yeah.
Dr. Dev, we want to know what is the advantage of dural puncture epidural over regular epidural?
The advantage of dural puncture epidural is obviously if you make a puncture in the dural, and this is more or less a theoretical advantage, which because there hasn't been a lot of studies actually proving this. What happens is because of that puncture, the onset of analgesia is faster and the patient satisfaction and comfort is better. So there are some studies which say that the analgesia quality is better and the onset is faster with the dural puncture epidural analgesia.
Yeah, thank you, Dr. Sanjay. I think that more or less covers almost all the questions that are in the chat box. And I want to thank all the panelists for their time and their excellent contribution to this very, very detailed discussion on labor analgesia. And I hope we were able to do justice to this topic.
And there is another question here. If we have to convert to cesarean, what doses and drugs do you suggest, or do you suggest spinal in that case? I think when the labor epidural catheter is already there, why you are going for spinal? Even if the fetal distress is occurring at that time, I think you give already the test dose or the first top up already been given. You just have to top up with another doses with now with the anesthetic doses of the ropivacaine or levonavine or whatever the doses you are using for your labor epidural. I think
you activate the labor epidural.
It will take another 7-8 minutes to get the effect. I think.
Absolutely. Absolutely. Okay, over to Dr. Bajwa to conclude the session.
Ma'am, I think before concluding, there should be some suggestions or I think direct questions they can ask by raising the hands from the audience who have been sitting here for the last 2 hours. They can raise their hands or they can ask directly by unmuting themselves, or they can give suggestions to this panel discussion. A lot of effort has been put up into this panel discussion.
So we can, is it audible?
Yeah, madam, please. Go ahead.
Dr. Srilata. So if there is any chance of converting to cesarean section, so we can increase the concentration and we can do under epidural the cesarean section.
That's what I said, ma'am. Just concluded that only. We can use the concentrated form, the real concentrated form of the local anesthetic, and we can go ahead with the required doses according to the patient height and the requirement already doses given up in the previous top up of the epidural. We can go ahead with the.
So as I am working in Counter Institute, so I have given the thesis topic for comparison of labor analysis with the levobuprofen and ropivacaine. So the chances of instrumentation is less with ropivacaine. So we have done 100 cases, 50 cases with bupropion, 50 cases with ropivacaine. In that, we have concluded that instrumentation that is low outlet forces, sir. Minimal with ropivacaine when compared to bupropion.
Ma'am, your voice got getting broken. Question is not clear. The last part of the question.
So we have done cases of labor inertia with the bupropion and ropivacaine. So with the ropivacaine, instrumentation is less when compared to bupropion.
Ma'am, if you go by this, now it's a question of a different level. The question with the ropivacaine, a direct comparison of two drugs. Ma'am, actually, first of all, the drug equivalence has to be calculated. Which drug is equivalent to what level of the analgesia, what type of number of fibers, the degree of fibers involved. Second, we have to do a power analysis of the study before instituting such studies actually into the research platform. So we cannot claim it's observation. It's an general observation.
Observation.
It's with ropivacaine, you have got a more instrumental delivery, but that's not conclusive. Till we really formulate a good research question, make a power analysis.
In our experience, I am telling you.
Experience is okay, ma'am, but I think before concluding that this drug causes the more of this instrumental delivery, it is not appropriate in the light of the statistical and the clinical evidence based on the drug equivalency also, ma'am. That is to be there.
Okay.
Dr. Naresh, you can unmute and yeah.
Sir, good evening. Sorry, I joined late, but when I joined, I heard that there is some discussion on the intrathecal catheter insertion for labor analgesia. Is it true that somebody is using intrathecal catheter insertions? Otherwise, we are using epidural catheters. Intrathecal are quite unsafe. So I want to have some.
Dr. Anand, that was as a treatment for accidental dural puncture, not the routine use of intrathecal catheters.
Okay. Means we should put the catheter there?
Yeah, if you have an accidental dural puncture, you have two options. Either you remove the catheter and resite it at a different place, different space, or you can insert the catheter into the intrathecal space and use it as an intrathecal catheter.
Is it somebody practicing the intrathecal catheter for labor?
Yes. It's a recommended technique and it reduces the incidence of post-dural puncture headache.
So how much dose concentration is used in intrathecal catheter insertions?
So you can use about 2.5 milligram or 1.5 to 2.5 milligram of bupropion with about 12.5 microgram of fentanyl as a bolus. And then you can either use it as give us 1 to 3 ml of infusion of 0.1 to 5 of bupivacaine or 0.06 to 5 bupivacaine, depending on the patient's condition, underlying condition, and the pain, along with 2 microgram per ml of fentanyl. So either that or intermittent boluses.
Somebody has also asked about availability of fellowship programs. I would just like to say that AOA India, which is Association of Obstetric Anesthesiologists India, has fellowship programs in a few states all over India. One is in Rainbow Hospital and Gangaram Hospital in Delhi. Then we have in Fernandez Hospital and Rainbow Hospital in Hyderabad. And we have in Ramakrishna Institute in Chennai. And these fellowship programs are very good. They have a very organized fellowship program, and it's a 1-year program. And towards the end, they also have a exit exam of both theory and practicals. And all our fellows who have passed till now have come out to be very good obstetric anesthesiologists. So you can go to the aoaindia.in website and check the details and apply for it. Otherwise, you can contact anybody from the AOA, president, secretary, or me. I can help you or guide you if you want to join any program, or any of your students who want to join this program.
Dr. Shilpa ma'am, here I interrupt now. It's a very administrative question. How many people can really join a fellowship? How many can in India for a fellowship? Rather than the better initiative is providing a skill center, a highly skilled center where many of the people can go. I think practitioners, ma'am, when we are talking about the labor, we cannot rule out the practitioners who cannot spend 1 year for fellowship, leaving their practice and family. I think.
No, this is for students who just passed out.
No, I'm talking about.
This was a question in the.
I'm talking about other part. I'm talking to higher level, little higher level than ma'am. It's not students only. I'm talking about.
Yeah, for higher level, if you're a practitioner, I would recommend.
I'm talking about a whole. The skill center, the ISA has already started their programs of identifying the skill centers where you can go and have a training. You can have the labor epidural, you can have the ultrasound guided blocks, you can have anything. So those skill centers, they can provide you a training for 3 to 4 weeks. I think that is going to be good for any practitioner. They can sacrifice 1 month of their practice. They can go to that skill center, and that training is free of cost. No burden on the candidate, but only the logistic part they have to take care of. That I think we are trying to identify in each zone and each state. Almost quite a lot have been identified, and we are in collaboration with them. So many in the new website, we will be putting up those skill centers. They have to apply through the ISA. They can go and have a very practical training within a 3 or 4 weeks for that week. And I think that will be good enough for everyone. For students,
I think that is what everybody does. Even for regional anesthesia, they would go to a center where, a lot of regional anesthesia is practiced, and go as an observer, at least for a week or 2. And this is how everybody is upskilling themselves.
That's the way, ma'am, because we trying to have in every state. People cannot go from, say, Jammu to Kanyakumari to have this training there. It's difficult for them. Rather having a skill center very near to the state so that they can have, because sometimes people really want to have something, but they are missing on that. I think we have already started that initiative to make them aware about going to particular skill center and having a hands-on training. I think under the supervision of the best person, because the skill centers are qualified centers and which are under the supervision of the best person in that category.
That's a very big initiative taken by SA.
Yeah, Dr. Malvika, you have a question?
Hello, ma'am. This is purely for the academic purpose in a teaching institution for the postgraduates. What should we say? Like, is it the use of lignoadrenaline epidural test dose? Is it controversial when asked in a practical exam, or should we say like
your voice
is getting broken.
Your voice is breaking off.
So basically, if I've heard it correct, the question is in a theoretical exam using.
Can you hear me now, sir?
Yeah, you're audible, ma'am.
Okay, so this is in a teaching institution for the postgraduate exams. If asked in a practical exam, should we say it as the use of epidural test dose is controversial, or we can use it? It's for the theoretical purpose.
Just for It's to answer the examination question.
Yes, yes,
It
ma'am.
is controversial because in labor epidurals, the actual the purpose of giving a test dose is not justified in labor epidurals. So even though it goes intrathecal, like even though it goes subdural, it can cause so much of hemodynamic instability in the mother. Ultimately, we are not justified in giving. So it is controversial. So they can directly say that giving test dose in labor epidurals is controversial. Giving test dose in other kinds of epidurals, they can be carried on.
So this is as per the SOAP guidelines, which is Society of Obstetric Anesthesiology and Perinatology. Since 2005, they have come out with a declaration that every dose is a test dose. Every epidural dose is a test dose in obstetric anesthesia, because the risk of even migration of the catheter in laboring patients who are moving a lot is very high. So Kaushalya has very beautifully already explained why 3 cc of adrenalized xylocaine should not be considered as a test dose. So in your examination, you can say this as per the SOAP guidelines, which is followed throughout the world.
Dr. Parna ma'am has raised her hand. Ma'am, please unmute yourself.
Hello, everyone. This is in connection to what Dr. Bajwa was saying about the training for labor epidural. So, like way back in 2010, I myself have taken training in one of the centers in South for labor analgesia, and that was a 10 days course. So, we all can take some time out and take the training like that. And that's right, that all of us cannot do fellowship, but postgraduates can keep it in mind, and we seniors can go to such centers and take training so that we also upgrade ourselves.
Absolutely, absolutely, Dr. Panna, very well said. Can we bring it to a close now?
Yes, ma'am, sure.
Okay, let me share my screen for felicitation of all our faculty. My screen is visible?
Yes, sir.
So I'm really thankful today to Dr. Vimi Rivari and team. They have done an excellent job, and the topic is not so easy if you go by the discussion pattern and the standards. I think a lot of myths, doubts may still be prevailing. Somebody asking on the skill center, no problem about that. You can always write to ISA and at you whenever you want to get ready. We can provide you with the list. You can go to that center. Second part is the discussion today. It was very helpful. I personally feel it, because many things you cannot do practice. You cannot compromise with the safety of the patient unless you have got evidence. So I think the institutions are the leaders in these type of things, providing a labor analgesia to the parturient and to the newcomer in the world. So everything has to be on the safer standards. Everything has to be taken into account. We cannot do experimentation. We cannot do anything adventurous on the table, because we are dealing with two lives at the same moment. And it's not about the anesthesiologist, about the obstetrician also. It's about the other parties also, staff also. Everyone is involved in taking care of such patient. And for all these efforts, I'm really happy and pleased to felicitate our eminent faculty. Dr. Vimi Rivari, is your certificate first. Dr. Kausalya Madam, is your certificate. Dr. Shilpa, your certificate. Madam Bharti, aapka certificate.
Thank you.
Dr. Shrilatha, Dr. Samina, Dr.
Thank you, sir,
Dev
for
Sanjay Nag,
giving the opportunity, sir.
Dr. Tanveer, for
Yeah.
helping us facilitating this discussion today. And thank you, Dr. Bhavna.
Thank you so much, sir.
So this was a felicitation from the national headquarters for all the efforts and the pain and the time you have taken out from your busy schedule to throw light on a very, very controversial, commonly practiced, and yet evolving procedure. I think we are doing the maximum in India, maximum in the world rather, all the labor, because considering the population of India almost touching with China, so I think we are much higher. Must be number 1 in the world if you go by the labor epidural analgesia. So really, hats off to you to take part in this discussion. Now, before closing, I will ask my program head is not there, na, Dr. Manoj? He's not there. So I will ask Dr. Nishant and Dr. Madhuri to close the session with involving Dr. Tanveer and Dr. Bhavna.
Thank you very much, sir. I thank the moderator, Dr. Vimi Rebari ma'am, the panelists, Dr. Kausalya Chakravarti, Dr. Shilpa Kasodekar, Dr. Bharti Kalra ma'am, Dr. Srilata and Devnath sir. I thank the academic facilitators for today, Dr. Tanveer Singh and Dr. Bhavna, and all the participants for the academic deliberations. So thank you, and with permission of Bajwa sir, I think we can close the session.
Thank you.
Thank you.
Thank you, everyone.
Long live ISA.
We always end up saying by long live ISA.
Long live ISA.
Long live ISA.
Long live ISA.